It is my absolute pleasure to introduce Dr. Erin Reilly, who's the recipient of the 2024 UCSF Department of Psychiatry and Behavioral Sciences Early Career Psychology Clinical Innovation Award. This award was established to honor early career faculty who demonstrate outstanding innovation in clinical care, significantly enhancing access, quality, continuity of care, and patient outcomes. Dr. Reilly's commitment to advancing clinical practice, particularly through improving outcomes for those who suffer from eating disorders, and to service that bridges the research practice, academia, frontline gap, has set a remarkable standard for excellence within our department. Her creative approaches to piloting collaborative treatment development projects, including pilots of interoceptive exposure and PCIT, DBT for eating disorders, that also serve as training and mentorship experiences for frontline staff and trainees exemplify the spirit of this award. As an awardee, I want to remind folks that Erin and Sasha both receive a monetary award of $1,000 from the vice chairs of psychology, and we're honored to hear her talk today. We'll give a brief bio. If you give me the opportunity here, Dr. Erin Reilly is a licensed clinical psychologist and assistant adjunct professor in the department here. She completed her training at the University of Notre Dame, the University at Albany, SUNY, and the University of California, San Diego. Her NIMH supported research and broadly focused on better characterizing predictors of response to current treatments for eating disorders and using this knowledge to formulate novel interventions. She is passionate about mentorship and improving quality in the field of clinical science, and thus has been involved in leadership roles within the Association for Behavioral and Cognitive Therapies, the Society for Science of Clinical Psychology, the Coalition for the Advancement and Application of Psychological Science, and the Academy for Eating Disorders. I'm so glad you're here. Come on up.
Thank you so much to Barbara for that very kind introduction. And thank you all for the opportunity to talk a little bit about a topic that I am very passionate about. I can tell you all the people in my personal life are grateful that I have a venue to talk about this so they can stop hearing about it over cocktails elsewhere. I'm going to talk today a little bit about efforts that I have undertaken with colleagues to try to better address this gap that we all know very well between science and practice in our work. Like Sasha, most of this work would not be possible without a really amazing team that I have of mentors, collaborators, and folks that have supported my work. This here are just the folks that I'm currently collaborating with, mentees and trainees who are incredible and, again, really get this work going. And throughout, I will give credit where credit's due for these incredible projects. I've been incredibly lucky and blessed to receive training at a range of different institutions and work with some of the best folks in the field, both within eating disorders as well as clinical science and psychiatry more broadly. So this work is really a labor of love and a group effort. Some background on who I am. So like Barbara mentioned, I'm a clinical psychologist by training. I initially began my work as an undergraduate in a developmental psychology lab. I've always loved adolescence and identity development, and that's really where my passion began. I got my PhD in clinical psychology, like Sasha mentioned, in cold Albany, New York. We focused there and got a lot of training on psychological treatments and specifically cognitive and behavioral therapies. My fellowship, I was able to come out to the West Coast, and receive in-depth training within eating disorders and expand my work to consider more broadly neurocognitive processes and neurobiological processes relevant to treatment. I spent some time as an assistant professor on the East Coast at Hofstra University, and now in 2022 came out to UCSF, where I'm now supported by a career development award, where I've been able to attempt to integrate methods from cognitive science, computational psychiatry, and bring those things into the treatment realm. As an aside, as you can see here from my moving patterns, I'm happy to give advice if anyone needs tips on moving across the country, because it's happened a lot. I wanted to provide a little context as to why I care about this topic, this scientist-practitioner gap. When I began my training at the University at Albany, I couldn't believe how lucky I was. I really found it challenging, perhaps like many of you, to figure out what career I wanted to pursue because I found myself really drawn to quant. I loved math, I loved science, but I also loved working with people. And so figuring out what the heck am I going to do in terms of a career that can really blend these things. And I really found it in clinical psychology. First-year students at University at Albany take a course called the Scientist Practitioner Model. And we read things like this article here, The Local Clinical Scientist, and we talk a lot about this ideal of bridging science and practice. For folks that know me personally, I'm pretty even-keeled and probably about mid to low on positive affect. But after this class, I left completely positively dysregulated. I couldn't believe, again, this ideal of integrating these things, applying scientific method and scientific thinking to humans, the most complex thing of all time, incredible. Second year and beyond, I started doing clinical work and doing my own research, and some negative dysregulation came into play, right? A bit more complicated. My goal today is that hopefully we can prompt some thinking and discussion amongst our teams and across teams about how we can better kind of integrate research within clinical practice and vice versa. I wanted to provide a quick kind of history lesson on the scientist-practitioner gap. Folks might not be aware of this, but prior to World War I, the primary providers of psychotherapy were psychiatrists. Psychologists more often were in academic settings conducting research. We were the Skinners and the Watsons, right, doing animal research and more basic research. But with folks returning from World War I and World War II with mental health concerns and what we now know to be post-traumatic stress symptoms, there was an increased need for folks who provide direct care to patients, right? And so such began innovation within training models for clinical psychologists, where we attempted to blend both this kind of scientific training alongside provision of clinical care. And we know too that similar models exist within medical education. So for many of us, right, we have these kind of complementary, ideally, roles. When we're providing and doing research, we want to be thinking, how can we ensure that our studies are clinically relevant? How are they centering stakeholder priorities? And when we're in the therapy room, thinking about things like how can we engage clients and practitioners in research? How can we disseminate the work that is being done in labs like we have here? As well as actually thinking about our interactions with clients as scientists, right? That local clinical scientist concept, when we're working with clients and formulating case conceptualizations, thinking about testing hypotheses, integrating data, right? And taking that methodological approach. When you describe it there, it's a really beautiful thing, right? It's kind of a masterpiece. My experience trying to integrate science and practice is more along this lines, right? There's a ton of barriers to integration of science and practice that we're all very well aware of, but if you indulge me, I'll go through. Right, we all know from providing care to patients that the complexity of clinical reality is just not yet reflected in our treatment options. Specifically, if we look at RCTs and the representativeness of the samples within RCTs, they do not reflect who we are seeing in our patients, both in terms of their identities, as well as their presenting problems, the complexity of structural issues and how that's not been integrated. This I could talk about probably for decades, but the other thing that has struck me in my experiences has been how is information created and how does it flow within the field, right? We here in academia in this prestigious university are now the creators of knowledge that is then disseminated to frontline clinicians and patients, right? It's a one-way flow, and it has this kind of power and hierarchical system that I think ultimately limits us and limits the care that we can provide for the patients. Relatedly, like this is a question I try to ask myself as regularly as possible, thinking about who is at the table currently for determining what are priorities in our work. What do funding agencies prioritize? Who are in those conversations and how do those conversations and decisions get made? That limits, I think, the integration. I know this from personal experience and working with clinicians. There's a ton of challenges, and we all know this here, right? We have all the resources in the world, and collecting rigorous data in our clinical applied practice is extremely challenging. There are so many barriers to this, right? Logistical, administrative, et cetera. And we know ultimately that those barriers limit our care with patients. When we have data that doesn't necessarily generalize to our work with patients, or it's challenging to generalize, we're more apt to rely on our clinical intuition and heuristics, which we know can be helpful, but are laden with biases, right? We live in a flawed society, and when we don't have data that serves us well, we might be more apt to, again, decrease the quality of our care. So a ton of barriers here, and the goal of my work is ultimately to address these barriers over the next however many decades I'm working, thinking about barriers to integration within science and practice. Sasha gave a great context, but I'm going to just give a little bit more context on eating disorders because this is the specific clinical context in which I work. Eating disorders and disordered eating more broadly are extremely prevalent, costly to society, and it really associated with significant suffering, right? Estimates indicate that over $60 billion a year cost is associated with eating disorders, right? And the other thing, like I mentioned previously, is that there's a ton of misconceptions about who gets an eating disorder and what contributes to eating disorders, blame associated with eating disorders that I think poses a huge challenge for advancing knowledge and serving the populations that we work with. Specifically, there's a thinking about this gap between science and practice. Like many other subfields within psychiatry, almost all existing treatment research for eating disorders has been developed on samples that are prominently white, affluent, cisgender girls, right? And so this is extremely limiting in terms of, particularly when we know that eating disorders affect everyone across all identities. Most treatment approaches, again, similar to psychiatry more broadly, are kind of this one-size-fits-all approach. Our manuals are wonderful, but they don't provide a lot of matching to the clinical complexities, whether it be with comorbidity or otherwise that we're seeing in our patients. The other piece, and this is maybe a little bit, I need a little bit more nuance here, but over the past decade, there's been this huge emphasis on neurobiological research and pushing forward the biology, which there's been a ton of great kind of benefits of this in terms of decreasing blame and pushing forward mechanistic understandings of disorders. But at this point too, a lot of this work has yielded few immediate actionable insights, addressing and highlighting a need for work that's kind of bridging that gap between more basic and applied contexts. There's also a lot of problems with the existing treatment landscape in eating disorders. And I hope that, again, I'm highlighting eating disorders here, but I think that a lot of these problems are shared across our clinical contexts. We know that patients have really limited access to evidence-based care. Several of our team members are working on this issue. Most higher levels of care for eating disorders, which are commonly used, are owned by private equity firms. They're for-profit institutions, and they have not and do not publish on their efficacy, which again has a lot of related problems. We also know that on front lines, many care providers diverge from evidence-based recommendations or use unsupported techniques. And again, I want to kind of counter the kind of traditional reaction to this, which is often folks will hear this and say, we need to figure out how to better engage clinicians in implementing our evidence-based treatments. And what I have, and I'll talk about in a moment, and try to flip this and say, let's better understand why clinicians with this expertise and knowledge are finding that this is not the right fit for what they're seeing in their patients. And so I'm going to give, similar to Sasha, with 20 minutes, you kind of have to do a sampler platter. So I'm going to go quickly from a bunch of different things that I have been working on with collaborators that try to address some of these gaps. If you want to talk more about any of these projects, please come find me, email me. I'd love to chat more. I'm first going to talk about a couple of examples of ways in which I've tried to bring practice and expertise from practice into science. The long-term goal of this work is really to try to prioritize the perspective and voices of frontline clinicians and patients at research at every stage. Ongoing process, a challenging one, but one that I found really humbling and fun. The first example of this was during my fellowship at UCSD. I had read an article about a group at Columbia that had done a research psychoeducation group with patients and thought this was really fun and wanted to implement it. And so I had done my work within a PHP IOP setting, and so asked to have some time each week with the patients where I would go in, ask them what their research ideas were, ask them what they wanted to learn more about in terms of the research, and then kind of formulated didactics and discussion based on those preferences. So I'd bring in articles that had been written, I would develop lesson plans based on what their priorities were, and we'd read them together, discuss them. I also would sometimes bring grant ideas and ideas for papers to them. And it was an incredible experience for many ways. First of all, extremely humbling. I now will, almost every time I undertake a new project, try to think about, if I can't do it personally, I'll visualize it, bringing your work to patients, because they were not shy in telling me why would you want to research that? Everyone already knows that. Or, what would that actually do to help our lives, right? And their candor was frankly quite helpful in clarifying for me and thinking about why do we want to do this research anyway? Certainly, and I'll talk about in a moment, there is value in work that is methodological and less applied, but really a wonderful takeaway for me. The other thing was the patients gave a lot of feedback related to the articles themselves. Now, the patients were fully able to read the articles, digest, discuss, but they had a lot of feedback on how we're writing about things. The other piece is that, right, the terminology and the writing of the articles feels unnecessarily complex and obtuse, right? And so thinking about, it was wonderful for me to try to break this down with them and think about the fact that the only reason that for many of these articles were in their hands is because I accessed them with my library subscription at UCSD and printed out copies that we then read together, right? These patients otherwise would not have access to this information that is being done on them, essentially. The second initiative I'm going to talk about, I did in collaboration with Ayla, who is a wonderful graduate student at Hofstra University. It was based on an initiative developed by Marv Goldfried at Stony Brook, which was initially informed and based off of efforts by the FDA. So y'all probably know this much better than I, but when a drug is being undertaken or surveyed for approval, there is a process through which practicing clinicians can give feedback on delivery of and experiences with that drug. And so Marv Goldfried developed this two-way bridge to provide kind of a parallel in psychotherapy and engage clinicians in providing feedback in delivery of evidence-based treatments. And so Ayla and I undertook this in collaboration with folks providing cognitive behavioral therapy and family-based therapy for eating disorders. The first paper from this collaboration was published in Behavior Therapy recently, and the other paper is under review. And in these papers, clinicians were able to give feedback on what techniques from these treatments are they using, what doesn't fit, what are the major barriers that they see, and what are areas that they want to see new in terms of ongoing research. And it was really cool to see because after this was done, Ayla is currently doing her dissertation, and it was based on some of the findings from this initial paper, right? And so we really felt like, okay, we're actually getting priorities and engaging folks who are practicing and really seeing these patients in what they care about. The last example I'm going to briefly just talk about is one of several that I undertook alongside folks practicing. Again, this is kind of addresses this issue related to flow of information. How am I determining what kind of treatment development projects am I taking on? I was on the East Coast working with folks at the Child and Parent Psychotherapy Services Clinic, providing some supplementary supervision. This is a clinic that is primarily focused on providing PCIT for younger kiddos. And Dr. Orr pictured there and Lauren Webb were noticing that they had more and more clients presenting to their clinic that had co-occurring selective eating concerns. And they said, we have no idea how to address this, but we really want to address it. It's a parent priority here. And so in collaboration with and in response to this kind of clinical observation, we developed and have been piloting a new module that we've added on to PCIT, focused on addressing selective eating within their population there. I'm now going to briefly kind of wrap up through specifically talking about the opposite, right? Bringing science into practice and give you two examples of ways in which I've tried to take with collaborators, data-driven and scientific methods, and use them to solve clinical problems. The first example of this is my current K23 award. The question that it really seeks to answer is, can we use tools from computational psychiatry, right? Applying these mathematical equations of how folks learn and make decisions. Can we use them in the treatment domain? Can they have this applied value? Specifically, I'm interested in whether understanding and characterizing how people learn and make decisions can predict how they're going to do in existing behavioral treatments for eating disorders. This, in an ideal world, results are not in yet, can address some problems that we have here, right? We all know that within this kind of precision psychiatry framework, all the disorders we treat are quite heterogeneous, right? And this precision psychiatry approach, broadly defined, is attempting to take these different sources of data, whether they be biological, cognitive, self-report, and use them to kind of create these clinical biotypes that can inform design treatment. I still think that we are probably decades away from what is pictured up there, but this is kind of the first step that we're undertaking. We're taking and surveying, recruiting adolescents with anorexia nervosa. We provide them with a battery of neurocognitive tests, apply computational psychiatry tools to characterize different contributors and influences on their learning, and seeing whether that predicts how they engage in family-based treatment, which we argue may operate because of some of these behavioral and learning-based principles. As another example that we've undertaken or beginning to undertake in collaboration with Karthik Sarma and Caitlin Hahn, two wonderful psychiatry residents, we're thinking about and beginning to try to use innovations within artificial intelligence, and they're really the experts here, to improve screening and access to treatment in eating disorders. Here we're addressing a little bit of a different problem. There's a huge unmet need for improved screening and digital delivery of eating disorder treatment. Sasha and I have taught over the past couple of years a mini course for second-year medical students, which is super fun. But a common thing they'll bring up is, how do we better screen? How do we understand best screening practices when they're in primary care or other specialties? And there's really not great tools available. And so Karthik and Katie have been fantastic in thinking about potential ways in which AI, and specifically large language models, might begin to address that gap. However, at this point, as anyone who has used ChatGPT knows, there's a lot of potential issues with harm in these tools as well, right? Issues with safety and potential for harm, with misinformation, which I think is true across the board, but certainly is going to be the case in psychiatry, and is definitely the case when we're thinking about using AI to ask questions related to diet and weight in a society that has a complicated relationship with those things. And so this work we're undertaking with Katie and Karthik, along with other collaborators, looking at, can we develop a back-end approach to improve the safety and screening of these AI tools to ultimately deliver screening and virtual interventions. Some takeaways and food. Okay, some takeaways. I asked the folks that primarily identify as researchers here, of course, we all identify in both researchers and clinicians, but researchers in the room, I challenge you, as I try to challenge myself, to ask yourself a couple of questions based on what we discussed today. First is how we can better engage stakeholders early in the research process. It has become more and more clear to me how critical this is. And ultimately, even in some of my ongoing projects now, I find that I think about this too late, right? The research project has already been done, the grant is already approved. And in that way, that limits the amount that we actually can integrate stakeholders' opinions. And so the more I've learned so much from my colleagues and those with specialty in community engaged research and their methods that they've been doing for decades, and thinking about their kind of modeling of bringing folks in at the earliest stages of research to determine priorities, who gets funded, and what we're doing. Always asking ourselves, picturing ourselves in front of that room of patients in the psychoeducation group presenting our research idea. What are they going to say? Will this improve their lives and our existing treatments? Again, I want to highlight, I'm a methods nerd. I love statistics. Not every paper I write is going to be of interest to everyone, but really just kind of coming back to this and really allowing it to center our priorities. Thinking about, and this is a challenge for me, but I like thinking about it, is how are we disseminating our work beyond peer-reviewed journals and academic conferences? What are innovative ways that we can take back our findings to the community and to the populations that we serve, engage clinicians in kind of a back and forth, not just a dissemination of what we think? How can we invite rather than exclude folks with an invested interest, and really advocate for work conducted in naturalistic settings? I didn't talk about it today, but a value of mine and thing I love doing is partnering with clinicians and helping them disseminate innovation that they're engaging in their work, whether it be through case studies or think pieces. And one thing that has struck me is that in trying to publish naturalistic data, we completely get skewered by peer reviewers, right? This isn't rigorous, there's all these issues with it. And I think that while, certainly many of the points are valid, I do think that that is sort of discounting what this work can provide in terms of innovation and knowledge to the field. For clinicians, I really encourage you, like I mentioned, participate in the empirical literature. No, I'm always, when I have my clinical hat on, I can tell you 10 times out of 10, I would rather read a case study, a think piece, an innovative kind of clinical paper versus an RCT in JAMA, sorry to say, right? So thinking about disseminating both of those types of work for folks who are practicing. holding researchers accountable for the clinical implications of their work, partnering with folks in your clinic or otherwise to kind of influence what's being asked and how it's being asked. And then thinking about and discussing as a department, what are tools that we need as clinicians to better collect data that can answer questions of interest to ourselves and our patients. Thank you for letting me chat. And again, happy to talk and answer some questions. Thank you.